Now, welcome to this session where we're going to talk about how technology and data is helping to transform the financing and delivery of healthcare. As some of you may know, there's a report which came out which says that 57% of Africans do not have access to a bank account. Meaning that these people are not able to participate effectively in the economy. And the consequence is that some of these people, when they fall ill, they cannot pay for care or even become more poorer. So, globally, that also leads to about 100 million people becoming impoverished when they fall ill. On the other hand, we've seen in Africa that mobile technology, the use of mobile technology in economy and other sectors is improving, such that mobile transactions occupy or covers about 10% of the GDP transactions in Africa. So there's a huge potential for mobile technology and the payments around it to really transform health, not only on the delivery, but on the financing. And, I have a panelist with broad experiences working in different areas to share their experiences. So on the panel, we have Dr. Peter Kamunyo, CEO of National Hospital Insurance Fund in Kenya. We have Dr. Bernard Okoboy, CEO, National Health Insurance Authority, Ghana. We have Dr. Ntuli Kapologwe, who is a director at Health Unit at the President's Office in Tanzania. And last but not the least, we have Dr. Nico Speaker, CEO, Pharmacist Group. So we're going to have interaction with these panelists for about 45 minutes. And then we open up also to questions and observations from the audience. And the audience can share their questions through the Q&A part of the platform. So welcome to all of you to this webinar. Very important webinar talking about financial inclusion, and we are fortunate to have this plenary session. So without much ado, I will, let all of you, for the purposes of the audience who may not be familiar with your work, to briefly introduce yourself and give the highlights of the work that you do. So Dr. Peter Kamunyo, if I may start with you, if you can talk briefly about the work that you're doing in Kenya and how that's critical for inclusion and universal health coverage.
All right. Thank you, Kwasi, and hello, everyone, from wherever you're dialing in from. My name is Dr. Peter Kamunyo. I work for NHIF, that is National Health Insurance Fund. Kwasi, we were able to change the name in January this year with the amendment of the new act. And NHIF is, as a national health insurer, whose key mandate is basically to provide access to quality care to all Kenyans. As you've heard, that our act was actually amended in January this year, actually assented by the former president on 10th of January. And the main purpose is in the reforms that we're going through to transform NHIF into a strategic purchaser of healthcare services, and at the same time, the vehicle for us to be able to achieve universal health coverage. Kwasi, it is interesting that in the topic we're talking about financial inclusion, and every time we're talking about universal access, I think the issue of finances is something that we cannot fail to talk about. And that being like one of the key pillars of UHC from where I sit, which is economic empowerment as the #1 pillar, because as we know, the biggest challenge that most people have is that out-of-pocket expenditure. And by using vehicles like NHIF, where the risk is transferred, we are able to economically empower people. So I'm very happy to be here. And unless you want me just to continue with a little bit of my submission, then you can move
please
on.
Please go ahead. Yeah.
Okay, great. So this being the key pillar of UHC, which is economic empowerment and the risk transfer, then the next pillar is to ensure that everybody is on board. So even as we are looking at that empowerment or the financial inclusion, is to make sure that the tools that we have, that everybody is onboarded. And even in the Act, as we amended it, it was to ensure that that happens. And one of the key things is that we obligated every Kenyan to be a member of NHIF. And because we know that is not a realistic position for everyone to be able to afford, then the government was also obligated to identify and support those who cannot afford to pay. And this is a process that in Kenya we have been going through. In fact, 20% of the indigent population, as identified in our last census of 2019, have been already supported by the government. So we are talking about 1 million households, indigent households who cannot afford basic necessities of life, including healthcare, have been identified and are able to access benefits and healthcare through NHIF by having their contributions paid for by government. So in that process of ensuring everybody's on board, we're looking at ways and means to make sure that it is made easy for people to pay, to remain constant members. Because having everybody on board, one of the biggest challenges that we've been having is that most of the population actually pays only when they're sick. So in fact, and the statistics show that very clearly, like for voluntary membership, which is about 8.4 million households, at the end of the last financial year, only 14% were active at the end of the year. And this is not good for sustainability or financial health of the institution, and neither is it good for social protection, which is what we are looking for, because then it means 86% of people would be caught flat-footed should they get a catastrophic health occurrence at this point in time. Then the final pillar that we're looking at, that we're supporting also as NHIF, is the benefits, ensuring that the benefits, whatever it is that they're paying for, is benefits that are available, benefits that are accessible, and benefits that speak to the needs of the people. And towards this end, in part of our reforms, we actually just recently rolled out our new contracts with our over 8,000 providers countrywide. And what is interesting is that in our provider panel, we have both public, private, and faith-based. And one of the key highlights of our new contracts is that we harmonize the reimbursement across all levels of similar institutions. So if it's a public hospital level 6, for example, whether it's public, private, or faith-based, we reimburse at the same rate, and that continues down. And this, what it will spur is that these institutions will be able to work towards also attracting and providing care that is of quality, and because the reimbursement is at the same rate. So that's what people will be fighting for. And even some research that we did fairly not too long ago showed that one of the key things that patients look for is actually consistency of care. So we are hoping that with this, the hospitals will be able to have enough resources from the reimbursement to continuously improve on quality. So with these 3 pillars, we are looking at scaling up to ensure that every Kenyan now has access. And the other 2 key reforms that we've been doing, which are also key for this workshop, is a digital transformation. And we'll get to that very well. And then organizational transformation. So I'll be happy to talk about that when the time comes. Thank you very much, Kwasi.
Thanks a lot, Peter, for emphasizing the social protection aspects of your work, but also the reform that has taken place, to enable you to offer insurance across the country and across different segments of the population. Thanks a lot. Dr. Kapologwe, Are you there? Yeah. It's really a pleasure to meet you, and I think last year we also have the same interaction. Very important the progress that you're making in Tanzania, where you have NHIF and I believe ICHF, which is also being transformed, and recently you have UHC Act discussed in Parliament. So please take us through what you're doing so that the audience could get a bit of context for this conversation.
Thank you very much, Chris. My name is Ntuli Kapologwe. I'm the Director of Health, Social Affairs and Nutrition Services at the President's Office, Regional Administration and Local Governments here in Tanzania. So the history of insurance in Tanzania is a bit unique from the rest of African countries, but it started in 1996 when we did pilot in one of the districts in the northern part of Tanzania. And ever since, we have witnessed the evolution of the insurance. But mainly in Tanzania, the insurance has been divided into three categories, where we have for the formal sector, which is under the National Health Insurance Fund, but also we have those for the informal sector, where we have the Community Health Fund, and those who are catered by the private sector. But for the informal sector, this is where there is a lot of investment which has been put for the past 15 years or so, and there's a number of reforms which have been implemented to make sure that it becomes palatable and also responds to the people's needs. One of the key reforms were to actually have the provider-purchaser split. Initially, the patients were the ones who were enrolled into the scheme whenever they visited our primary healthcare facilities. And later, as per insurance principle, it became quite very clear that subjected us to the adverse selection, where majority of those who were into the scheme were the ones who were sick. So we had to actually engage the farm access, engage the health promotion system strengthening projects, which is under the Swiss Development Corporation, to come up with an improved version of the Community Health Fund, which could later go into splitting the role of purchaser and provider, and also helped to digitize and digitalize the enrollment process in the country. So these are some of the reforms which have been implemented to make it improved Community Health Fund. But the notable and the most important reform was to come up with an information system, which is the Insurance Management Information System, which allows the people actually to get real-time data countrywide. The country, Tanzania, is a big one. It's among the biggest countries in the continent, but we can manage really to have information at hand within very short period of time. So that also allows the enrollment officers who are based at the community level to use the mobile phone technology to enroll people at the community, to register them at the community, and allow them to pay premium at the community. And those are funds which are collected at the community can be pulled at the regional level through the Bank of Tanzania account. And that has helped a lot in terms of misappropriation of funds, the accountability, transparency at different levels, because the enrollment officers, they also have the ownership of the funds collected at the community level. But apart from that, this has also helped the facility to be able to track and also to get their reimbursement back. At the same time, these enrollment officers to be incentivized whenever they enroll a single a community member into the Community Health Fund. So these are some of the things which have been done as far as the improved Community Health Fund is concerned for the past 5 or 6 years ago. And we have witnessed now the accountability has been increased, and also the transparency has been increased from the national level up to the community level. So the digital platform space, to us, we take it as a great opportunity which has helped to transform the insurance system in the country. I'd like to submit at this point back to Kwesi. Thank you.
Yeah, thank you very much for emphasizing the uniqueness of the scheme that you have in Tanzania, and the expectation is that with the new USC Act, that the Community Health Fund will be revived, and that what the government has already done in the past of supporting the payment of premiums for people will be a key part of it. Thanks a lot. We will come to the digital part at the second part of the conversation, but I go now to Nicole, Speaker, CEO of Farm Access, to share with us some of the key highlights of what she's doing. Nicole.
Thank you, Kwesi. And first of all, congratulations to the colleagues from Kenya and Tanzania for taking amazing steps forward in achieving their ambition for UHC. I think we see with a lot of development partners, we're often looking for sustainable approaches in 3 to 5 years, along with funding rounds. But I come from a country of the Netherlands, and we are relatively good in providing UHC, but it took us 50 years to implement it. So first of all, please do it faster than we do it, but also recognizing that these are journeys that take time, and really everybody should take that time to really implement it thoughtfully. We are an organization called Farm Access. We help partners like the national insurances, the governments, but also private sector partners to achieve universal healthcare coverage. And with our colleagues here, we talk a lot about making sure that there are financial packages to pay for this, which is a very important aspect. We need to lower the financial barriers and ensure financial inclusion, and come up with strategies where those who can pay and those who are healthy contribute to those who cannot pay and those who are sick. That is what true solidarity is about. And those mean setting up trusted systems where we all see the benefits of having a healthy population supported by a healthy insurance program. But it's not just about demand-side financing. So as an organization, we really want to support not only an enabling environment that achieves demand-side financing, thinking about good packages, the policy environment that is needed to really institutionalize and embed insurance programs, but also making sure that there's quality of healthcare provision. So thinking about setting standards for healthcare facilities. We do that, for example, through our own safe care methodology that is really an architecture that partners can adapt and adopt. Here in Tanzania, where I'm calling from at the moment, very successful in PPP approaches, setting the same standards for public and private healthcare facilities owned by the government to make sure that when people go with their insurance card to a healthcare facility, they are offering the quality that they are supporting. And then we also really help with public-private partnerships, recognizing that 50% of the healthcare facility, 50% of the services in the countries that we're talking about today are being accessed through private healthcare providers. A lot of them faith-based, which typically serve the lowest end of the market, but also sort of the middle segment with private healthcare providers, not forgetting about the very important role of pharmacies and others in providing those services. So really thinking, how can we do proper contracting them, making them fulfill that role while avoiding the trap that we're always afraid of increasing costs unmanageably. And I think that is, again, where insurance plays an important role. So we're very keen to start this discussion today, also thinking about the opportunity that digitalization brings in, because I think without digitalization, we will not be able to achieve universal healthcare coverage. But let me hand it back to you, Kwasi, before I'm tempted to already dig into this fabulous topic to manage the conversation.
Yeah.
Back over to you.
Yeah, no, thanks a lot, and also congrats to you and the team in Tanzania that this week the Queen of the Netherlands visited Tanzania, and some of the initiatives happening, and yeah, thanks a lot also for explaining the context in which pharmacists work and some of the key initiatives that can help drive the financing and delivery of care. So, we cannot have this conversation without talking about COVID, because, for one thing, it made us become more aware that health is wealth, and that health system strengthening is important. And Peter, maybe as an insurer here, most insurance agencies in Africa, and maybe also for the greater part of the world, COVID was, but particularly in Africa, COVID was treated outside of insurance. So it wasn't included in the insurance package. But going forward, everybody knows that epidemic is here to stay. So how, in your perspective as an insurer, what would be your advice in terms of how we can prepare and respond effectively to future responses as an insurer, but also, yeah, maybe let's discuss that first, and then we take the other part.
Right. Thank you, Kwasi. I think with COVID, there were many lessons, first of all, learned. And I think also one of the interesting things was also another element of surprise in terms of the extent of the impact that it had. And I think it has been documented in very many places that it also exposed the soft underbelly of our healthcare systems. Now, starting from an insurance perspective, when it was declared a pandemic, it basically left the realm of a risk that you can actually bear, because as a pandemic, you do not know the extent, you do not know the magnitude, you do not know the length of time, and it becomes difficult for insurers to be able to do a risk profile for something like a pandemic. And that is why in most policies you would see that pandemics are an exclusion. Also, in addition to that, like from where we sit, that NHIF is also unique in terms of its financing, because NHIF is 100% financed by contributions of members, meaning that then the total top line is finite. I can actually tell you if everybody contributes, what is the maximum that we will have. And it's based on that we also calculate the benefits that will be discharged. So anyway, that said, I think also very many countries have, like Kenya, in case of a pandemic, there's what we call the Public Health Act that kicks in, whereby now also the government takes responsibility. And actually, it goes all the way to an extent that they can even take over hospitals and be able to discharge to help the citizens. So like in our case, we did present these facts, and because also NHIF having a wide network of reimbursement mechanisms, that if when funded, it can be used also to be able to compensate the institutions or folks who are providing those services. So I think that was the big learning in terms of when we have pandemics, how do we also finance or how do we channel the finances that probably come from central government to be able to support not only the healthcare institutions, but also the people? Because, in a pandemic, we might get lost and only look at the patients, but looking at the healthcare delivery system is also very key, and including even supply chain, etc. So I think there's a lot of conversation, and I'm happy now that we're starting to live with it, because with the lessons learned, we'll know what to do, and we'll be better prepared for the next pandemic, God forbid, that should come along. But I think it was a great learning. But also another very interesting learning that we had is that because of social distancing, the people not being allowed to aggregate, we found that our voluntary membership actually grew during that period, because many people were left exposed. They couldn't do the social, contributions for hospital bills. So people realized that they actually need to transfer their risk. And we had a lot more voluntary contributors actually join during that period, and which was another positive outcome.
Yeah. No, it's important to see that, and I think the lesson that we shared, you could also have the same lesson in Ghana. That and what we're going to also discuss later, important lesson is how digitalization became so crucial. But before we continue this conversation, I think Dr. Okuboy has joined us. So, are you here?
Yes, thank you very much.
Thanks for being able to make it. I know it was a difficult, day for you. The nice background, pictures and stuff.
Thank you. I love the arts.
Yeah, no, very good, very good. It's an important piece of creative mind. So we had an introduction of the panelists, because we feel it's important for the audience to understand the context of this conversation. So briefly, if you can share with us what you're doing and what you consider to be the highlights of your work in Ghana.
Yeah, thank you very much. And let me once again say a very good morning to all my colleagues, and I'm happy to be here to learn together and to share our experience. So Ghana, as we speak, the National Health Insurance Scheme covers about 60% of the population. We have 60% of a population of 30 million. So we always are doing between about 16 to about 18.5 million out of the 30 million, all on the National Health Insurance. And so it's a very big one. And 90% of the funding comes from taxes and pension contributions. 90%. Just about 5 to 10% comes from premiums. And I always say that our premiums are tokens and not premiums, because people are supposed to pay non-pension contributors, that's those in the informal sector, pay about $2 as a premium for the year. And when you are paying $2 for healthcare for 12 months, you know it's not actually a premium. So we fund it through taxes. Like I said, about 90% from taxes and pensions. Over the journey of 19 years, I can say that where we are is one that is way better than where we started from. In 2003, when an act established the National Insurance Scheme, we had a country that was very poor when it comes to access to healthcare. There's about 30% of the population could access healthcare. Today, access is over 65%, and it's largely because of the health insurance scheme. And we are still even trying to deepen it further in pursuit of UHC. We are trying to make sure 80% at least of the population can access care. So these are three main things that we are doing. Number one, we are trying to find out how to use technology to encourage registration onto the scheme. That's renewal of membership. So in the past, you had to go to our physical office before you can renew your membership. Now, with a code, a short code, *929#, you can renew and pay with the mobile money on the phone. And this has taken out traffic from our office, about 70%. People now don't have to go to the district office. That's the first one. The second one is that claims processing. One of the biggest threats to the scheme was that it took too much time to vet claims, to submit them, because it was 90% manual. In the past 6 to 10 years, 90% of claims management was manual, only 10% electronic. And as we speak, we are on a very wild drive to make sure that we get to 100% electronic management of claims. And I'm happy to say that we've moved from 10 to about 70% in terms of submission of claims. A lot of facilities now do electronic submission of claims. That's the bills on patients. So the electronic process, of course, comes with very high efficiency. So we are not spending 90 days now to manage a claim before paying. From the time of submission by the hospital to the time we pay, it's not 90 days. Now we are looking at an average of about 45 days. And we hope to beat it down further by the end of the year to about 30 days. So that's the second one. And the third one, to improve efficiency, is now to make sure that the first time in 19 years, people can actually go on an app on Google or iOS, download our app as a scheme, register there for the first time, pay using an electronic card or mobile money service, and then get active without coming anywhere near our office. And we are in a modern world where, like they say, it's a WhatsApp generation. So if you can't put things on apps, people can't get close to you. And I believe strongly that this will further enhance our drive to get to 80% access to healthcare. So in a nutshell, technology is wild on our card, and we believe we can do a lot with it. Thank you very much.
Yeah. No, thank you. Thanks a lot for the explanation. I also think that, you know, an important aspect, as you emphasize, which, you know, and that's the purpose of this webinars and exchanges, that other countries can also learn from Ghana is the role of government spending, you know, taxes. And I think if the other countries can get that into individual contribution, I think they will be able to really extend coverage. And thanks for also explaining how, you know, with you using technology in that aspect. So we were talking about COVID and its impact, and there's a question here, and please feel free to add. After that, I'll go to Nicole for some of the things that Pharmacist is doing to address these challenges. So there's a question about, shouldn't the NHIF and the ICHF have a reserve fund to address epidemics?
Yeah, so let me say that.
Maybe hold on. So then this is more for Peter. So someone would like to know, and also for Ntuli, someone would like to know whether within your scheme there should be a reserve fund to address pandemics.
Thank you, Kwasi. I think, and for that question, it's actually a great question. And is there an institution that, like NHIF, that 100% relies on contributions, meaning that we're taking risk? So it's running like an insurance company. So definitely in terms of financial strength and sustainability, must have reserves. And the reserves to ensure, you know, sustainability and any big bumps, you know, to the extent of like an epidemic. But like I said, reserves for a pandemic are difficult to calculate because of the nature of a pandemic, because you do not know the extent, the level. In fact, it can get to a point whereby even that which you're paying for is not available. Because if a pandemic, for example, decimates the healthcare provision, then the promise that you've given as an insurer becomes null and void. So I think for pandemics, and in terms of preparation for pandemics, preparedness for pandemics, as governments, that's very key. But also now looking at the learnings that we had, for example, then how do you pay for it if it's being supported from government? Which channels are you going to use? That is the conversation I feel that we should be having. But in terms of taking risk for pandemics and preparing for risk of a pandemic as an insurer is very difficult until you learn the disease itself. If you look at HIV, for example, it used to be a pandemic and nobody was touching it. But after we understood management of the disease and were able to do the risk profiling, then now we're able to actually offer even insurance cover for it. So I think it is a learning. and that's a process that will continue. Thank you.
Yeah, thanks. And I'm sure Nicole would like to share something on this, but let me first go to Dr. Ntuli. How did you address COVID, and how can you respond also to this question?
Thank you very much. For us, I think that's not very different from my colleague from Kenya, Dr. Kamunyo. Actually, the central government stepped in.
There's a break here. I hope it's not on my side.
I don't hear him anymore. We lost him.
Okay.
Can you hear me now?
Yeah,
can you hear me now?
Yeah, please.
So, sorry for that. And as for Kenya, the government stepped in, and we didn't add any restriction in terms of the insurance, but the central government was mainly responsible with the preparedness and response to the pandemic. As you know, in Tanzania, we didn't add the lockdown. So other preventive measures were going on as arranged from the Ministry of Health. But in terms of the response, then we had different stakeholders coming, but under the leadership of the government. With regard
yeah, please go ahead.
In terms of the response to the pandemic, and next year, as you and a special meeting, one of the main emphasis will be now on are we going to actually have pandemic prevention, preparedness and response. So for me, I feel that it's high time that we should look at and how best we can have the package on the pandemic. But again, I allude to what Dr. Peter has said, understanding the nature of the pandemic, that will give us an edge on how best we can come up with the package. But the most important thing is what now the Tanzania is trying to do, embarking into the universal health insurance. When you have all the people enrolled into a scheme, then there will be risk sharing, financial sharing. All these can offer an opportunity for us to be able to respond or to make our healthcare system responsible as well as resilient to the number of health events or shocks. So for me, as for Tanzania, I'm very happy that it was last month in September when we tapped the bill for the universal insurance, and this month it will have the public hearing, and of course there will be discussion at the House of Representatives to come up with the universal health insurance for our country. Hopefully, the implementation will start next year. So for me, that will be a huge opportunity as we move towards universal health coverage by 2030. Back to you, Kwesi.
Yeah, thanks a lot, Dr. Ntuli. Nicole, you are a key advocate for integrating vertical funding into a horizontal system, because if it's about health system and universal coverage, you've got to strengthen the system. And you have some experiences to share here about why vertical programs have done good, but going forward, a new model is needed. And there's also a question here about if you want to look at the disease specific, maybe another way is to see how they can all be channeled into epidemic preparedness fund. Your take on that. So 2 questions in a sense.
Thanks, Kwesi. Indeed, my favorite topic. I think it's such an important topic to have because when it comes to setting up financially strong health insurance system, there's 2 words that are the most important. It's risk and it's trust, right? So the risk that you can manage the finances, which is in the startup of any scheme, is difficult. I think Ghana has been extremely successful with a 60% coverage, but I know it's been with taking a lot of steps, learning what the cost and what the utilization is, a learning that is still ongoing. And knowing this information can manage the risk of unexpected payouts. But for many of the countries, that learning is still in its very early phases. And what happened when the COVID pandemic started, everybody was afraid of the risk, did not cover sufficiently or not at all the cost of the pandemic. It lost the trust of the patient that, you know, these systems were there to respond to them. But it also turned back all of the development support and international support into a very traditional vertical funding, giving supplies to African countries, giving PPEs, giving vaccines. And we can all look to ourselves and say, as an international community, I don't think we did a really good job being, you know, creating solidarity with the continent that needed it more than anyone else. So I think let's learn from that. And I think the important part is we need to get to a model where countries themselves know best how to procure medication, supplies, commodities, and are part of that same international market instead of waiting for handouts or waiting for these big international programs to start. So COVID learned that we're not ready for that. We went back to vertical funding. In fact, I think we crowded out some of funding that may have been allocated for the more traditional diseases. And we need to have a much more sustainable model. I think it was Peter who mentioned HIV used to be a pandemic, and it's now a disease like other diseases. COVID will be like that. And then it comes down to trust. We know we need to de-risk some of these finances because they are high risk. So for insurance companies, how do you manage a pandemic that will probably happen, but we're not sure when, and we're not sure what it will look like? So having a de-risk fund where we can also bring in some of these solidarity payments to de-risk that, so you have a basic healthcare package that is much more predictable in financing, but de-risk some of the pandemic responses. But also we know, for example, that certain pregnancies can be very high risk that will need extra support, and you can finance that. NCD is something we don't talk about enough, but we know it's one of the big growing concerns. It's out there, and we don't really have a strategy of financing something that's going to affect the majority of the adult population that is driving the economy, because these are working people. Using technology can integrate that. You can set up de-risking funds like the pandemic preparedness funds, like a fund de-risking high-risk pregnancies, or NCD healthcare provision. And that funding is only triggered when somebody really shows up at a healthcare facility accessing those services through their mobile phone. So you create the transparency that this is really happening. You also create, importantly, a lot of information, right? We know very little from the COVID pandemic on the African continent. We don't know really anything at all about the effectiveness of vaccines and who are the risk populations. And if we would have that information, we could do a much smarter pandemic response moving forward that is tailor-made for the African continent. Now, technology is able to reduce this fragmentation, pool this funding at the level of the individual so that they are covered for all diseases, creating the trust that the healthcare system is working. And at the same time, also creating trust from the various partners where this funding may come from, that it's being utilized for those services that they want. And then I think the third and very important point, it's also going to create great efficiency and effectiveness, because all of these parallel funding streams come with their own overhead, come with their own inefficiencies. And for years, that was important because we needed to make sure that HIV money was reaching HIV patients. But in the age of digital technology, there are way more effective and efficient ways of achieving the very same thing, and also creating the trust with the patient that you can be an HIV patient with COVID that is pregnant, right? So diseases don't come knocking sequentially, they might come knocking at the same time. And this is able to acknowledge that. So really getting ready, and I think with the colleagues in this panel today, they are ready to do that. I think it's important that we as partners, but also the multilaterals that are hopefully in this call, are starting to get ready to see if we can start with some pilots, understanding how this integration is working, and created a trusted environment for all. Back to you, Kwasi.
No, thanks a lot. Diseases do not come sequentially. So the need for using the technology that we have to ensure efficiency and contracting that can deliver better value for patients. Thanks a lot. Peter, I know you have to leave. Are you there, Peter?
Yes, I'm here, Kwasi.
Yes. So before you, and thanks a lot for your time. And before you leave, there's a question about the digital transformation challenges that you have faced. And so we all agree it's nice. But what are the challenges?
All right.
About briefly, yeah.
Thank you. I think in the 57 years history of like NHIF, we have moved from a very basic operation that first of all was only looking at formal sector, then introduced voluntary contributions in 72. But a big milestone was in 2015 because the previous operation was reimbursement based on bed days. And if you recall, that used to be enough to take care of an entire hospitalization. But with the increase in complexity and costs of healthcare, that was far outstripped. And in 2015, that's when we introduced like outpatient. And outpatient was not on a fee-for-service model, it was on capitation model, and then inpatient packages. So meaning we transformed from a very basic reimbursement, rebate reimbursement model to a very complex insurance model with capitation, prospective reimbursement methods, packages, etc. And with that, there is no doubt that to be able to achieve that countrywide, you must have a digital transformation. And that was the fourth key pillar of our transformation. And I was happy to hear from Dr. Boye in Ghana that they've also gone e-claim. Yeah, for us as well, from last year, 11th of July, we are 100% e-claim. Access for patients is also through biometric registration. But I still feel we are still scratching the surface because the challenges, you see there we are addressing the bit of access and submission of claims, but there's so much more in terms of ensuring that we have the universe of the population. Because if we're talking about universal health coverage with over 80% of the population covered, we are looking at also populations that maybe have limited access to these digital platforms or limited literacy, also in terms of their financial standing. So how do we ensure we include all these people? And then one of the biggest challenges that we're having, remember I mentioned about members not being consistent, is one of the reasons that they cite is that they don't remember to pay, it is inconveniencing to pay, or they have erratic income streams. If you look at the whole year, they can afford the $60 or $50 that we bill, but it comes erratically over the year. So how do we use digital platforms to ensure that we're able to harness this, to ensure that there's constant payment, because that is the only way we can ensure sustainability. So now, in addition to that, also looking at the digital transformation is also inside, because now we need all this data that is coming in. How is it coming in? How are we using it to inform us in the decisions and the interventions that we are making? We know that in our part of the world, like standardization in terms of even coding, etc., is still not yet there. So we are working so hard to have interoperability of systems, etc. Is it time that we took a step back and looked at how do we standardize to make sure information is coming in a way that we all know? So there is a lot, and as we continue with the digital transformation, we look at, are we actually also addressing the needs of the people and to have the impact that we want? So we always have to start with the actual problem and look at the issues from the lens of, and I will call them the consumer this time, the patient, because what is their pain point and what are we doing in terms of digital transformation to address that pain point? Because like the biometric one solved a very big issue. We used to have one card for a family. So if a family member is sick, the principal member had to run home or to get to the hospital to provide the card. But now everyone, including the child, can actually have access using that. So I think the challenge is something we need. It's a conversation that cannot stop.
Yeah, thanks a lot. And also thanks for your time.
Thank you so much.
I know you have to go to another meeting, but thanks a lot. We'll connect later. Yeah.
And I'm really, really happy. Nicole, Dr. Ntuli, Dr. Boy, it has really been a pleasure. And Liam, thank you very much.
Yeah.
You're welcome.
Thanks a lot. Dr. Okuboy, there's a question here that links actually two things that you said. So, we are the financial inclusion session, meaning that people should have the means to pay for care, and you have taxes doing that. But the other side is the providers. They also have to be incentivized in a nice way that they will deliver the care and will not turn people away. And so the question is, how do you reimburse providers? Is it capitation? And if it's capitation, how can you ensure that they will submit it electronically?
Thank you very much.
Because,
so,
whether you abide by performance or not, you'll be paid. That's basically what the person is saying.
Yeah, thank you very much. So we are using largely the DRGs, that's the diagnostic related groups. So we pay for, let's say if it's a cesarean section, we have an amount, a tariff that we've set. And then once we pay you that, it's supposed to cover the procedure, the consumables you use, and all other things that come with it, including the laboratory investigation like full blood count and all that, which might be part of the service. So the diagnostic related groups is one that we use mainly. So if we pay you, let's say $1 for malaria, it's supposed to be it's supposed to cover the consultation, let's say the blood film examination, which will confirm it, and possibly an HB lab to look at your blood level. So we are doing diagnostic related groups where it's a package, it's an ingredient in there. We do this for the service, but when it comes for the medicines, the drugs, we actually do pay for fee for service. So for every drug that you write, we have a tariff that we've set for that drug. And I can say that almost every drug that has to do with every condition that we cover is captured in this list. And our package covers about 97% of all illnesses that are diagnosed in the sub-region or in Ghana. So that is quite extensive. And let me say that we are not doing capitation, but it is something that we'll be very interested in learning from countries like Kenya and other places where capitation is quite significant as a payment method. Now, let me say that we vet claims by using algorithms that are captured in our electronic vetting systems. We also still have some manual vetting that happens. And through this, we are able to tell whether what is captured on paper is actually what happened at the clinics. Another very key activity, which happens here at the authority, I wear two caps. I am the person heading the regulatory body, which is the National Health Insurance Authority. And at the same time, I head the scheme, which is the National Scheme, Medical Insurance Scheme. With time, that I'm sure we decouple because it's not fair, because I am regulating all players in the medical space, especially the private players. So let me say that at the authority, we are very much interested in ensuring that there is efficiency when it comes to what we pay for service. And at the same time, one key activity that we run here at the National Insurance Scheme is clinical audits. So we have a whole department whose work is to visit facilities, to have an idea of what they are doing and what they submit to us. And I'm happy to say that there are many occasions where the audits have led to a cut in some of the bills that are submitted to us. And we know very much that there is an extent to which physical manual visits can achieve success. There's an extent. The best way is technology. So as I speak, we are working with a solutions provider to have a biometric device or solution that will be deployed at every facility so that a patient who visits the facility is biometrically confirmed, either facially or fingerprints, to show that Mr. Kwesi was at this facility at this time, at this location, so that you cannot generate bills for people who might have visited your facility once, but you have bills covering 5 visits. And these also would help us to identify those who go shopping. There are clients who visit 5 facilities for one condition. Once there's biometric verification, we can even input it such that if you visit one facility today for malaria, when you try to biometrically verify tomorrow, it will have raised an alarm that is someone who had been seen just yesterday. But as we speak, currently, we pay more, sometimes we pay 5 times for the same condition because there is portability.
Yeah.
You know, so
but it's also a journey that you started and you're learning from it to do better, right? And,
absolutely. I mean, it's always a journey, like you said.
Yeah, great. There's a last question which I think maybe all of you would like to express opinion about, and I'll start with Nico. Nico, when you were talking about the need for synergy, integrate medical into you emphasize the importance of technology. So if there's something more that you would like to say about how you're using technology, please, you can do that, but also link it to the question here, which is technology generates data, but there's also challenges around data, privacy, and etc. How do you address that within your work? Can you hear me?
Sorry, who are you asking first?
Nico. Yeah.
Nico, okay. Oh, sorry, Ntuli, you're next because you're really the expert. Just a few minutes because I'm recognizing we're reaching the end of the hour, but data is incredibly important. Data is the future, and importantly, it's a resource that is just getting increasingly strong, right? And I think yet privacy is important. We need to be protective, but we also need to be careful that we don't start managing out of fear. There's a huge opportunity of all this data. We heard our partners talking about how it can help set up their insurance systems, but importantly, it can also help create better diagnostics for African country. Understand vaccine equity, better medication that we know is not always tailor-made, understanding comorbidities and comortalities, resource allocation and effectiveness of our interventions. So as this data is flowing there, we need to understand how do we create ownership, especially with the individual from who the data ultimately belongs, but also in the various countries, how do we set up institutes that can regulate on behalf of their citizens, that can protect the privacy, very important, while at the same time also unlocking the value of this data to provide stronger healthcare systems for the citizens it belongs to. So my 2 cents, and I think worthy of another webinar.
Yeah, certainly. But thanks a lot because we are also running out of time. Dr. Ntuli, briefly,
for us, we need to embrace data. And we need to embrace. Because initially we used to rely on the paperwork, but after digital transformation, really we had to digitize and digitalize. Now we can have real-time data. The analytics can be done locally at the national level as well. But far most important is the ability for the members of community health fund to re-enroll into the scheme whenever their premium expires.
Yeah.
But also with digital technology, you manage to have the QR codes, which actually hides number of information that can be easily revealed to another person. So the privacy and confidentiality is taken care.
Okay, thank you. I'm sorry, I have to cut it for the sake of time. So thanks a lot on that. And certainly we are working together as an organization to enhance the value of data in Tanzania. Dr. Kuboy, briefly, 30 seconds, any final words?
Yeah, so in 30 seconds, let me say that the good news is that in the next 1 month, there's going to be free elderly care in Ghana. That's 70 years and above. If you are 70 years and above, you don't have to pay any processing fee. All you need is your national ID card. You are registered and you can access care a minute after registering or a second. That is good news. We now have it only for pregnant women. All pregnant women have this service. We've extended to 70 years and above. And then secondly, let me say that with collaboration with pharmacists, now we have a data analytics unit so that with all this electronic drive, we can make use of information, engage in AI, and be able to do policies based on intelligence. And thank you very much.
No, thanks a lot. Thanks a lot. And I would like to thank all of you for an exciting conversation. Unfortunately, as it goes with all nice conversations, you know, the time runs quickly up and that we have to close.
Hello, Nicole.
But we will connect and the conversation will continue. Thanks a lot for your time.